and it's a great pleasure to invite you and to welcome you to this webinar on the Free-Cog, our scale for the assessment of cognitive and executive function. Before I start, I'd just like to thank a number of people. You can see that the University of Manchester and the University of Manchester Institute for Collaborative Research on Ageing is hosting this, and I'm grateful for my colleague Suzanne for doing this, and also the Greater Manchester Mental Health NHS Foundation Trust. And some of the funding for the Free-Cog came from the Royal College of Psychiatrists here in the UK. We have an hour and a half, so what we'd like to do is to, there's some presentations that we'd like to give. We don't necessarily have to take all the time, but some presentations about the Free-Cog. Suzanne, I wonder if I could have the next slide, please. So I'm going to say a few words of introduction, and then my colleague Julie Morris, who's a statistician, will talk about some of the metrics of Free-Cog. And then my colleague Judith Harrison, who's a psychiatrist in training, will give some practical experience about the Free-Cog in memory clinics. Our neurological colleague Andrew Larner unfortunately can't be here today, but I'll be presenting his slides. And then Ross Dunn, a consultant colleague here in Manchester, will talk about the electronic Free-Cog, and then we'll have lots of time for a discussion and any questions you have. And I know many of you have already contacted me about questions, and hopefully we'll get the opportunity to address some of these. When you have a question, please put it in the chat box. I'll do my best to monitor that, but my colleagues will do the same. And if there's any danger of you not being on mute, if you could pop yourself on mute when you come in. We'll try. I think we have the ability to mute everybody, but if you could pop yourself on mute, that would be very helpful. So please put your questions in the chat, and we'll see how we get on. Could I have the next slide, please, Suzanne? So the Free-Cog, the idea behind the Free-Cog came from something that myself and a couple of colleagues had thought for some time, and many of you will be aware. There are so many cognitive assessments available. The question begs, do we really need another one? However, most of the assessments that we have concentrate purely looking at cognition and not other things such as executive function. So what we wanted to do was to see if we could get a scale that assessed both. That's different to the global scales that we know that assess all sorts of things, but we felt that was important. The other thing that we wanted to do was to try and see if we could reintroduce the art of cognitive assessment. Now, the mini-mental state has been around since the mid-70s, and I think it's fair to say with all the other instruments that are available, and you will know them a lot better than me, that there's a tendency just to look at the score. And in many clinics up and down across the world, and up and down, I know here in the UK, often the first thing people talk about is the score, whether it's the score on the mini-mental state, the score on the Addenbrooke's cognitive assessment, the score on the Montreal cognitive assessment, or the GP Cog, or something like that. And what we wanted to do was to try and see if we could reintroduce the art of the cognitive assessment. And when we come back later and talk about the scores and the cutoff scores, we will have a discussion about that. So it's a novel scale. It's a hybrid scale, and it aims to measure both cognitive function, but also executive function. One of the things we did as well is that we were conscious that we wanted the scale to be driven by patient experience and opinion. And so right at the beginning, going back a number of years, we asked colleagues from the Alzheimer's Society, people with lived experience of dementia and their carers, what kind of things would be important. And some of the feedback we got was, again, it was that mechanistic, the question of asking. So people went right in and said, who's the Prime Minister, who's the Queen, what day it is. And we wanted to see if we could make it in a more conversational way. And I'm extremely grateful to people with dementia and their families and carers who helped us look at the way that the questions we were asking. We want people to use the FreeCog and tell us what you think about it. And I've had a number of people have written and said, do we need permission to do it? You don't. You can see the reference there. I think probably the copyright rests with the International Journal of Geriatric Psychiatry and John Wiley, but we're very keen for you to use it. And I know my colleague Jude will speak about that a bit later. So in terms of using it in particular populations, it would be great if we could build up almost a community of practice about the FreeCog to get and see what you think. Ross will talk about the electronic version. This is the first version of the FreeCog, and if we find in due course that there are things that can be improved, then it would be great to do that. Finally, we developed really just on the back of the COVID pandemic, which I know has affected all of us and has particularly affected the way that we organise memory clinics, the opportunity to remotely assess people. And so the Telefree Cog was something that we developed, which looks at the ability to give the FreeCog over the telephone. You can see the reference there to the FreeCog. That's freely available on any search engine. If you put in FreeCog Burns International Journal of Geriatric Psychiatry, it will appear as if by magic. Could I have the next slide, please, Suzanne? So you're all familiar, so we just wanted to keep things general. So the first question is something that's non-threatening, and I think there are some other scales where, you know, that first question could potentially put people off. So we wanted to start with a general introductory question about the news, and then inevitably we have to ask about orientation and memory and things like that. Next slide, please. So that was the first few questions of cognition. And then we went on, you know, tapping the various domains of cognition, visual, spatial, language, and fluency. Can I have the next one, please, Suzanne? And then finally, executive function. And it was in this area that we were particularly pleased that colleagues with lived experience of dementia were able to tell us exactly the kinds of things that were important here. All the scoring for the FreeCog is available there. And again, this is something we might come to in the discussion. I know people worry a great deal about, oh, what does this mean? If someone says that, do they get a point or do they not get a point? That's not what the FreeCog is about. And one of the most powerful things, rather than asking me what the correct answer is that if there were something like that, why not have a focus group amongst the multidisciplinary team and see what you think a correct answer is. And the most important thing, and I think my colleague Ross Dunn will come back to this later, is that the diagnosis of dementia, the type of dementia, mild cognitive impairment, normal aging, is not the result of a score on a test. It's a result of your judgment informed by the scores on the test. So again, that's something that we can come to later. So I'll move on. Could I have the next slide, please? So it's a pleasure to introduce my colleague, Julie Morris, who was the statistical genius behind FreeCog. And Julie, you're going to take us through some of the statistics and the scores that were in the original paper.
Yes, I'm the medical statistician who analysed the data from the FreeCog study. And so what I'm going to do is just to present just a brief description of the results. So in the validation study, FreeCog was tested on almost 1,000 subjects from 25 sites across the UK. Participants were referred for a memory assessment or had a diagnosis of dementia or memory impairment. Control subjects were those who had no diagnosis of dementia or cognitive impairment. You can see actually that the control subjects, or sort of the non-dementia subjects, were in fact slightly different in age. In fact, actually, the slide there, in fact, I think the wrong version is actually on there, because the control and the dementia columns, in fact, should be transposed. In fact, actually, it's the extreme right-hand column that are the controls, and they, in fact, were younger, and a greater percentage were females. But the disparity in age and gender was found to have no impact at all on the comparisons of the cognitive test scores between the three groups. So although there was some disparity in age and gender, there was no difference in terms of the performance on the cognitive scale. So can I have the next slide, please? So shown here are the very simple observed mean scores in each of those three groups, the controls, mild cognitive impairment group, and those with dementia. Total FreeCog, just to remind you, is scored out of 30. Cognitive FreeCog, it's one of the constituent parts, is scored out of 25, and executive function is scored out of 5. So you can see clearly here that in fact actually for the FreeCog groups, that in fact the scores were quite different between the three groups, showing that they differentiated well between controls, the mild cognitive impairment, and the dementia groups. And these the FreeCogs were actually compared to 3 other cognitive tests routinely administered in clinical practice: the Montreal Cognitive Assessment, the Mini-Mental State Examination, and the Addenbrooke's Cognitive Examination. And you can see that actually they showed, just as with FreeCog, quite good discriminative ability, and it's quite similar ability to differentiate between the three groups of the FreeCog compared to the other three groups. Although these are the simple observed means, in fact, after adjusting for that age and gender disparity, there was very little difference at all, which shows that, in fact, there was an absence of any confounding effect on the scores. Okay, next slide, please. The ROC curve here, the receiver operator curve, just shows the performance of FreeCog, shown in blue, and that of the MICRA, shown in red. And they're presented just as 2 different curves for differentiating between subjects with mild cognitive impairment and control subjects. And the plotted values here are sensitivity, i.e. the true positive rate, i.e. the proportion of the MCI subjects correctly identified by the test score, and 1 minus specificity, or the false positive rate, where the specificity is the proportion of control subjects correctly identified by the cognitive score. And the ROC curve plots these for different cutoff points, where the straight line actually shows a situation of 0 predictive power, i.e. labelling a subject as MCI or control just by chance. And you can see that the ROC curves for both the FreeCog and the MICRA are reasonably similar, again reflecting the comparable discriminative ability. Next slide, please. So lastly, if we choose different cutoffs relevant to this specific study group, you can see the sensitivity and specificity for using cutoffs looking at differentiating between 2 different groups of subjects. So for example, for differentiating between MCI versus controls for this study group, then using a cutoff point of 27, we can find that 75% of MCI subjects had values of 27 or lower, and 70% of control subjects scored 28 or higher. But note that these data are shown to assess the performance of FreeCog only, and the cutoffs here should not be considered as standard definitions of MCI or dementia. Okay, thank you. That's all the results of the study. So next
Julie,
slide.
thank you very much. We'll come back to questions, but I wonder if I could just ask, in your experience of analysing scales across the whole of medicine, not just in psychiatry and certainly not just in cognition, would you say that the FreeCog performs statistically reasonably well compared to other things from your experience?
Yes, I would. I think actually I was quite surprised when analysing the data to show that in fact you were getting from a very newly developed scale that you're getting such good sort of identification of sort of dementia and MCI, particularly MCI, for example, versus controls.
So it'd be fair to say that my genius surprised you. Would that be
As always.
Great, that's super. Julie, thank you very much. And I know that there may be questions. Could we have the next slide, please, Suzanne? So a pleasure to introduce Dr. Judith Harrison from Newcastle. Jude, you're going to tell us about your experience with the FreeCog in practice. Over to you.
Thank you, Alistair. So I'm Judith Harrison. I am a psychiatry doctor in training here in the United Kingdom and also a Wellcome Trust doctoral fellow. I'm going to talk about using the FreeCog in the memory clinic and community mental health for older adults setting. The FreeCog, as Alistair explained, was designed to combine assessments of both cognitive and executive function. It was also designed to detect significant rather than subtle impairment and to be more like a conversation than a test. It's also a concise instrument that can be used in a short space of time in a busy clinic and a busy clinical setting. Next slide, please. I'm going to run through some of the scenarios in which I find the FreeCog helpful. Other cognitive tests, as I've mentioned, detect more subtle cognitive deficits. Often it is the case when you're making an assessment of a patient that you've taken their history of cognitive problems and you have assessed their activities of daily living, and you've already formed a view on how impaired their cognition is. FreeCog I find useful to measure cognition where you expect deficits. Longer and more complicated tools can be very useful for the more subtle presentations, but they can be quite distressing and unpleasant or lengthy to do with patients who you expect to score more poorly. And so I find the FreeCog particularly helpful for the more impaired patient group. Next slide, please. Another patient group in which I find the FreeCog particularly helpful is among anxious patients. So it's known anecdotally, and there is also some evidence that patients who are anxious tend to perform less well on cognitive assessments. And the reason for this may be that worries and intrusive thoughts can compete with working memory and make it more difficult to perform well on these tests and assessments. I find that FreeCog's conversational style as part of the design can be very useful for patients with performance anxiety. Next slide, please. The other way in that the FreeCog can be very useful is in the context of patient monitoring. So patients who have perhaps been established on treatment or who have an established diagnosis. The FreeCog can be completed in around 5 minutes. So this is ideal for a follow-up appointment or for a busy clinic schedule. As Alistair mentioned, we did develop a telephone version to facilitate remote consultations at the start of the pandemic, which can also be used in this setting. One important thing to note is that whilst this demonstrated the selection of questions that are suitable for the telephone version had sufficient sensitivity and specificity and performed reasonably well compared to the other tests, we did not specifically trial it on the telephone. So there are other areas of research that could be expanded from the FreeCog. That is one of them that requires further study, is how the FreeCog performs on the telephone with the telephone version that we have suggested. Thank you very much.
Jude, thank you very much. That's a very important perspective, and going through those individual patient scenarios is extremely powerful. Just a quick question. We mentioned about the conversation and the fact that we were very fortunate to have people with the lived experience of dementia and their carers, if you like, begin to tell us about the effects of cognitive testing. How important do you think it is in your practice, Jude, to be able to, if you like, have a conversation rather than, as I said at the beginning, to dive in and say, what day is it? Where are you? And there's some other cognitive tests that we know start with quite, hard questions. Do you think that's important, or do you think that I've just overplayed that and exaggerated that?
I think some patients seem to find that more off-putting than others. Some people definitely seem to struggle more when they're put on the spot. And I think for those patients, this tool is particularly useful.
Right, excellent. Jude, thanks very much indeed, extremely helpful. Could I have the next slide, please, Suzanne? So Andrew Larner is a consultant urologist at the Walton Centre in Liverpool, not far from where we are. Andrew unfortunately can't be here on the video link. I'm not sure if you're able to listen, Andrew, so it would be great to get any feedback that you had. Andrew has a long track record working in a cognitive function clinic, largely to do as a neurologist, I think it's fair to say, with younger people, rather than the type of old age psychiatry clinic that myself and Jude and Ross would be involved in, and so brings a very unique perspective. You saw on the previous slide that Andrew wrote about the FreeCog early on from his experience, and these are just a couple of slides really just giving some of Andrew's experience. It's always uncomfortable presenting other people's slides, a bit like wearing someone else's socks. So I'll just do my best to see if I can do justice to Andrew's study. So he started off with 141 people with a diagnosis of dementia, and he used a cutoff. And again, Julie will come back to this about the various cutoffs. They may be different in different centres, and probably the next iteration of papers that we write about the FreeCog will try and harmonise this. And colleagues who are on the webinar, if you've got experience, that would be extremely helpful. And so Andrew used a cutoff of 22 out of 30 to get a sensitivity of 1 and a specificity of 0.67 for the diagnosis of dementia. Now, he talks about the maximal Yarden index. Andrew knows a lot about statistics, and apparently this is a statistical charm that, if you like, maximizes, gives you the maximum number of where the maximum amount of discrimination will be. Julie, if I've got that wrong, perhaps in the conversation later, you could correct me. So using that statistical method, he found 22 out of 30, and he's got this fantastic thing, the snout rule. So for a test with high sensitivity, a negative normal result effectively rules out the diagnosis of dementia. So any test and a sensitivity of 1 doesn't get any bigger than that. So a negative normal result effectively rules out dementia. So I think what Andrew is saying, that if you get over 22, then the chances of having a dementia are relatively small. That's not to say there won't be people with dementia higher, but that snout rule is really important. And Suzanne, I think we've arranged for a version of the slides to be sent out to participants after this. We'll make sure that the correct slides are sent out. And so I found this extremely helpful. So that was Andrew's experience for the diagnosis of dementia in his clinic, which would probably be younger people with different types of dementia. Can I have the next slide, please? Andrew obviously sees people as well who have got mild cognitive impairment, and again, using the same cutoff, a sensitivity much lower on this occasion, but a specificity is higher. And so he applies what he called the spin rule, and that's with a test of high specificity, a positive result rules in the diagnosis of MCI. And again, Julie, perhaps as part of the conversation when we're talking about the cutoffs that you had, talking about in groups, coming back to the individual cutoff. But again, just to emphasize again that the individual score should only be taken as a guide as part of an assessment of the person. And again, we're only looking at people with mild cognitive impairment and people with dementia and people with control and control subjects who don't have either. And in fact, you don't need any instrument to tell the difference between these groups, but certainly a score is not necessarily. So I think the spin rule is very good as well. And the next slide, please, Suzanne. Jude, you mentioned the Telefree Cog, and again, this was something that, to be fair, we looked at afterwards. It caused some angst among the referees for the paper, because they said that we should have done it to begin with and we can't retrofit this. But certainly my experience and a number of colleagues on the webinar who I know in the UK, we've been doing quite a lot of our memory clinics remotely using the telephone or using a video link like this, and found it to be extremely helpful. We know there are other versions available, such as the blind MOCA and tests like that. But we thought, really just because of the huge effect that the pandemic had on our practice, that we should see if there was any specific difference using or omitting those tests that needed people to see. So the denominator was reduced from 30 to 21. In the paper, you'll find all the details, and using a cutoff of 10 out of 21, you can see the sensitivity and specificity for a diagnosis of dementia and for a diagnosis of mild cognitive impairment. So again, very interesting information, but if you like, a first tranche of information, and your experience will be much appreciated. Can I have the next slide, please? And so finally, these are just a couple of the papers. We've had one already, and do the slides just to remind you the full version of the FreeCog is available there, and Andrew's written something else about his experience with the FreeCog, and he and I have written an editorial for the Journal of Neurology, Neurosurgery and Psychiatry on the need, and really posing the question, do we actually need another test? Could I have the next slide, please? So I'll pass now to my colleague Ross Dunn, Senior Lecturer in Old Age Psychiatry and Consultant at the Greater Manchester Mental Health Trust. And Ross, you've done some fantastic things about taking FreeCog to the next level. Ross, over to you.
Thanks, Alistair. So my name is Ross Dunn. I'm an old age psychiatrist working largely in inpatient settings in Manchester, and have a research hat doing clinical trials in the clinical research facility here in Manchester. But I also do a bit of programming in my spare time, and I was keen to take what is a sort of freely available test and make it more widely distributable. So you can have it on your laptop, and you can have it on a website, and you can access this really very easily. So the aim was to keep it simple, to be a facsimile where possible of the printed version, and all that's used in the web application is some basic HTML and JavaScript. For those of you who are a little bit allergic perhaps to the technological end of things, that's every web page that you see. It's set out as a HTML table, so it might look a little bit early 2000s in terms of the web design, and that's kind of intentionally clunky so that when it prints out okay. Calculates it for you. I know from my experience in research that we get the summation of these scores wrong a lot. There's no info spread to a server, so there's absolutely no connection between the computer you're doing it on and any kind of data collection on the other side. Next slide, please. That's what it looks like. Branded for Greater Manchester Mental Health Trust and the University of Manchester. Scores in the middle, and hopefully very easy to see on moderately sized screens. Next slide, please. So the plan really is to have an Android application up and running by early 22. It'll be free. In other words, it'll be free to access, and it'll be free as in you can do whatever you like with the code. So if you want to translate it into another language, or you want to make it look different, or whatever you want to do with it, you can do with it. Again, there'll be no server-side application, but there is the opportunity, if you wanted to use this as a research tool, that you could opt in to providing server-side data collection and use it as a research tool to collect your cognitive scoring data. Next slide, please. And just as an aside, why would you be a doctor who writes computer programs? Well, it's kind of a version of 21st century literacy, really. Knowing what's surrounding you in this ecosystem where we're faced with technology and web pages and web applications and mobile phones all the time. It's good to get under the hood, I think, sometimes, and understand a little bit about what's going on. It's never been easier to learn to program, and you could download and install Python, a very simple programming language today, learn to play with it, and be up and running really within about a week. If it frightens you a little bit, you could do a Coursera course or something like that, one of these massively online courses, very cheap, very easy to access. And you can use it to solve a problem for yourself. Maybe it's that Excel spreadsheet that you have to do every month that you just despise. And you could probably avoid that with a little bit of Python. Next slide, please. Alistair, back to you.
Okay. Great, Ross. Thanks very much indeed. Sorry for that pregnant pause. Ross, thanks very much indeed. I'm not sure if I would be that able to do that. So if you don't mind, Ross, for the foreseeable future, I'll phone you if I've got a problem with these various things. But thanks very much, Ross.
Alistair, you've just internalized the ageism, that's all. You'd be well able for it.
So thanks very much, and that will be available on an Android, available easily. I think Jill, you had downloaded it, and you could fill it in, and absolutely great.
So yeah, the Android app won't be available until early next year, but I think Jill can supply the HTML page for anybody who wants to access it.
Great, excellent. So that's all the end of the presentation.